Let's talk about Chapter 18, Altered Mental State, Stroke, and Headache. So first thing first is, we've already spoken about this before, an altered mental status. Remember, not everyone is normally alert and oriented times 3. So we first need to determine what is this person's normal mental state. And then we can determine if they're altered in any way. If you go into an Alzheimer's facility or a dementia facility and everyone is confused, then that's their normal mental state. And you have to figure out, well, what's different today about this person? Same thing with people with Down syndrome or some condition like that. What's their normal presentation? Are they responding normally? What it really comes down to whether you're alert and oriented times 3 and then become altered, or whether you have dementia and then become altered in some way. What it all comes down to is this organ right here has been affected in some way or other. The brain can be affected by things like hypoxia, strokes, seizure, trauma, drugs, alcohol. I mean, there's many reasons why this brain malfunctions. But if this person is presenting in an altered way, this is the organ directly or indirectly affected. So you can kind of focus from there. Now, I've been using this acronym, AEIU TIPS, for my entire career. And when I walk in on a patient and their chief complaint is an altered mental state, I go down this list, and more than likely, you're going to encounter the reason somewhere in this list. We've probably all seen people who are drunk, so we know what they look like. They stagger around, they have slurred speech, nystagmus of the eyes, they act kind of weird, they're violent, they're happy, they're sad, all different kinds of drunks out there. The problem with alcohol is alcohol masks a lot of other different things. So if you have someone who appears to be drunk, they could also be a diabetic, and they have not been taking their insulin. And that's why anytime you encounter a person who just appears to be just drunk, you need to get a blood sugar level on them, because yes, they might be drunk, but they also might be a diabetic, or they might just be a diabetic. So we can't just go, oh yeah, they're just drunk, don't worry about them. Now, when it comes to seizures, so someone can be born an epileptic. People get seizures from head trauma. They get them from strokes. They get them from hypoxia. All different reasons why people develop seizure disorders. If it's a grand mal whole body tonic-clonic seizure where the whole body shakes, when you arrive on scene, this person is going to be in what's called a post-ictal state. They're going to have an altered mental state. They're going to be just really sleepy, really confused. And if it's a normal, regular seizure they usually have, they're probably going to come out of it pretty quickly. But again, if you encounter someone on the ground or in a bed and they're acting abnormal for one reason or another, and you happen to notice that they have oral trauma, they have bitten their tongue or the inside of their cheek, or they might have urinated on themselves, you can almost guess now, prior to arrival, this person had a full body seizure going on. Insulin, of course, people are diabetics. They take insulin, both injectables as well as oral medications. If they take too much, their blood sugar drops and they become altered. If they stop taking their insulin, their blood sugar rises, and guess what happens? They become altered. So insulin's a big thing for us. We go on a lot of altered people that are just not taking their insulin correctly. You guys already know what an overdose is. You take too much of something, and that could be drugs or alcohol or whatever. But imagine an underdose. Imagine if you're addicted to something, heroin, alcohol, whatever it might be, and you don't have the money today to purchase that drug of choice, and your body starts to revolt and it starts to withdraw. And these people become very sick, and they can become altered due to that. There are people, especially diabetics, who get kidney failure due to their diabetes, and when the kidneys cannot cannot filter your blood correctly. You become hyperkalemic, and the hyperkalemia can lead to this uremia, which basically means your blood just gets full of all these toxins that your body can't get rid of anymore because your kidneys failed, and they can have an altered mental status from that. Trauma, of course, should be pretty self-explanatory. They got schwacked in the head, or they're losing blood, or whatever it might be, hypoxia. Probably the number one infection that I encounter in the field is usually sepsis. This is seen in little children, and it's seen predominantly, though, in elderly population. This person has some kind of infection going on. It spreads to the entire body. It starts to affect the body physically, and then because of that, they go into shock, septic shock, and that affects their mental status. Also, meningitis or encephalitis, swelling of the layers around the brain, can also kind of squeeze the brain and cause an altered mental status as well. There's something called psychogenic shock, and that's caused by some kind of fear or psychiatric phobia going on, essentially. This person gets so scared that they can faint or become non-responsive for us. And of course, if someone has a stroke, they can become unresponsive. And a syncopal episode is a temporary loss of consciousness. And once the person usually winds up in a horizontal position, they wake up after that. But all these can lead to an altered mental state. And I'm just probably could add another 20 things to this, but this is probably the most common number of ones that I encounter. Let's talk about strokes. So officially, a stroke is called a cerebral vascular accident. So you'll hear the term CVA. Some people call them strokes as well. And we run on a lot of these. I believe now the American Heart Association says that a stroke is the number one cause of death in people over 65 years of age, at least a medical reason anyway. So there's two types of strokes we encounter. The most common one out there is called the ischemic stroke. Ischemia basically means reduction of blood flow and oxygen to tissue. So this person has a blood clot in one of the arteries of his brain. And because of this blockage, part of his brain is not getting oxygen. And this comes on quickly. I mean, 1 minute this person's fine, and a minute later they're having a stroke. This is also known as a brain attack because it's a very similar mechanism to a heart attack. That same thrombus that develops in a heart attack, causing this person to have a severe myocardial infarction, does the same thing in their brain, causes a brain attack. So you might hear that term as well. So as you remember, hopefully from previous lectures, a thrombus is a clot or an occlusion that grows at the site of the occlusion. An embolus or an emboli is something that floats up from another part of the body and lodges in an artery in the brain. This is seen from people who have what's called deep vein thrombosis. They develop blood clots in their legs. People who have what's called atrial fibrillation, they develop clots in their heart, and those clots break free and they flow to the brain and causing ischemic stroke. These come on very quickly, like I said, and we'll go through the signs and symptoms here. But that's the most common. Probably 90% of all strokes are ischemic strokes. This person, in most cases, is awake and alert. They might not be able to speak to you, but they understand what's going on. Their eyes are open, and their vital signs are usually stable. The one big problem they have, of course, is that blood clot. And this is a time-sensitive injury. And I know we're talking about medical patients, but if you think about it, if you had a blood clot blocking an artery to a part of your brain, and that part of your brain that's not getting oxygen is dying right now, that's an injury. So this is a time-sensitive injury to the brain, and the faster you can get them to a stroke center, the more quickly they can recover from this condition. Now, the other one is called hemorrhagic, and the term hemorrhagic means caused by blood or blood loss. So this is a different kind of stroke, a little more rare. I see maybe 1 or 2 a year of these. They get missed sometimes because they don't present as a typical stroke, as we talked about earlier with the ischemic stroke. This is the person who ruptures an artery in his cranial vault, in his brain, and it's a sudden onset. It can be described as the worst headache they've ever had in their life. Then they go unconscious. They have seizures. They can get what's called deviated gaze, where their eyes look up towards the ruptured artery, and they're kind of stuck in that direction. So you walk in the door, and their eyes are open, and their eyes are looking up to the right or up to the left, and nothing you can do can make them look the other way. That's more than likely a hemorrhagic stroke. They're probably not going to have facial droop. They're not going to have those other typical signs and symptoms of an ischemic stroke. But you're going to hear the story of sudden grabbing the back of their head or grabbing their head and going, ow, my head, and then they go unconscious. And these people won't be talking to you because in most cases they're going to be out of it. Imagine you ruptured a large artery in your brain, and all that blood rushes into your cranial vault, puts pressure on your brain. You're going to be probably not going to be talking to anybody. So factors that make it more likely for someone to get strokes. A lot of this has to do really with your family history. Obviously, the older you get, though what's been happening now because of, I guess, our factors, societal factors and diet factors and all those things, I'm seeing younger and younger stroke patients. People in their 30s now are getting strokes, which this was typically an old person's disease process. Someone with chronic high blood pressure, you can only imagine if you had chronically high blood pressure and it kind of wears out your arteries, and then one of them pops in your brain and now you're having a hemorrhagic stroke. Again, there's that atrial fibrillation, which throws the clot, causes that emboli to float to your brain, creating that stroke. High cholesterol, which damages the arteries and the veins, like we talked about way back when in anatomy and physiology. It seems like African American, Hispanic, and Asian races seem to have a lot of strokes. And exactly why that is, I can't really tell you, but it seems to be just the way it seems to go. Diabetes, of course. Diabetes damages your blood vessels and leads to other kinds of problems. And smoking as well does this. So all these factors. So if you're old, if you have high blood pressure, high atrial fibrillation, high cholesterol, you're of one of the races that are high probability for this. Your mother and father died of a stroke. You're diabetic and you smoke. Lots of luck. So the number one consideration for strokes is detection. So the sooner that someone detects this person's having a stroke, or the person themselves realizes they're having a stroke and they call 911, the faster they can get to a stroke center and be treated, and the greater chance they have of recovering, at least somewhat, essentially. So the number one question when you're talking about sample history, the number one question you want to ask the patient themselves, if they can speak to you, or the witness of the onset, is last time this person was seen normal. When were you seen normal last? When was this person seen normal? Because that can give an idea of when this stroke might have started. There is a window of opportunity we'll talk about here in a few minutes for treatment for this. Once you think this might be a stroke, you're going to activate a stroke code, and you're going to go to the closest stroke center. And they're all throughout the county of San Diego. And in the treatment process on the way to the hospital, primarily you're going to do just a couple of things to them. One, you're going to get a blood sugar on them. And the reason why this is because if someone is hypoglycemic, they have low blood sugar, or they're hyperglycemic, they have high blood sugar, both conditions can cause stroke-like symptoms. They're not having a stroke. It's purely because their blood sugar is abnormal. So if you have someone with a facial droop, like you see here in this guy, they have arm drift and slurred speech, and you take their blood sugar and it's 800, they're not having a stroke. They're having hyperglycemia, which can be corrected at the hospital. So you're going to get a blood sugar on this person. You're going to provide them oxygen only if their oxygen saturation is below 94%, and you're going to position them usually on the affected side on the gurney on the way to the hospital. Once they get into the hospital, there's a number of ways that the hospital treats these people. One is they use thrombolytics, which are basically liquid drugs they inject into the person's body. And just like fibrinolytics they use for heart attacks, this reams out all of those clots from the entire body. They are high risk. Now, some hospitals like UCSD Thornton, I believe also Scripps La Jolla Hospital, and I believe Sharp Memorial, they use a catheter lab somewhat similar to the heart attack patient we talked about from another video, and they'll go in and ream those clots out, and this is proving to be a pretty good treatment for these patients, and it's allowing this detection and time of onset to be extended a little bit. They can treat these people outside the normal window of treatment with these specific treatments. So signs and symptoms, there's a whole bunch of these signs and symptoms. The most common ones you'll hear about is facial droop, arm drift, and slurred speech. In fact, the County of San Diego, if you read the protocol, those are the 3 parameters that they want you to assess. So have the person smile. If one side of the face is, facing down and the other side of the face is facing up, essentially, there's droop on one side of the face, that's a positive sign for a stroke. If they can't hold up one arm, if they can't maintain the 2 arms out straight in front of them, or if they can't move that side of their body at all, then that's a positive finding. If they're not able to speak, or they're using words that aren't appropriate, or they're slurring their speech, then of course any one of those 3 is a positive finding for a stroke, and you should activate a stroke code at the closest stroke center. But there's more into it than that. Those are just the 3 parameters we use here in the county. But you'll also want to think about, ask the patient, do they have any vision problems, especially in one eye or the other, or hearing loss in one eye or the other, essentially. So it's not just those 3 parameters. It's a whole bunch of stuff. We'll go through it. So there's your dysphagia. That's that speech problem. They can't express thoughts. They can't use the right words. Slurred speech, sudden severe headache. Then again, that's associated with the hemorrhagic stroke. And sudden loss of balance or trouble walking. So if you arrive on scene, and let's say you arrive on scene and the wife calls you because her husband kind of acted kind of funny for a couple of seconds. He was slurring his speech. He appeared to be staring off into space. She calls out of concern. You get there and the guy's completely fine. He has no symptoms whatsoever. And you check him for the facial droop and the arm drift and the slurred speech, and he doesn't have any of those signs or symptoms. But you want to do one more thing, and I do this routinely on these patients. This is not an uncommon scenario. Is I'll have them get up and have them walk. Now, I don't know if there's any hikers out there. Anyone's ever done any long hiking through the woods? Unless you got a compass or a trail map, you're going to be in trouble, because when it comes to the human body, generally, pretty much everyone has one leg that's shorter than the other, or one leg weaker than the other. And if you walk just through a forest, eventually you're going to go in a circle. Just over time, you're going to wind up going in this big circle because one leg's weaker or shorter than the other. Well, the same thing with strokes. If you have this person walk across his living room and he starts to veer to the right or to the left, which is abnormal, then you can pretty much guess this person probably is having a stroke. It's kind of like my last test I'll use on these people, and just to make absolutely certain that there's nothing else going on here. And here's some more stuff, right? Dizziness, confusion. You get the idea. The problem with all this is you can see all of these signs and symptoms that I've been describing can be other things. It can be drug overdoses, it could be diabetes, it could be alcohol, it could be head injuries, it could be fever, infection. So you have to be very kind of inquisitive about this and ask questions and find out their history and all that. There's another type of stroke. It's called a transient ischemic attack. Now, a TIA has the same symptoms as a regular stroke. The difference is it resolves within 24 hours and there's no permanent neurologic damage. So this person presents with facial droop or arm drift or slurred speech or one of these signs and symptoms we've been talking about. You get there and they're presenting this way, but on the way to the hospital, this whole thing resolves. That's a TIA. And what's bad about a TIA is, yes, now they're fine, but of course, these are precursors to a permanent stroke. So they still need to go to a stroke center. They still need to be evaluated as a patient to try to reduce the chance of them having that big stroke later on. So scene size of assessment. We have to decide on, okay, what's going on with this patient? There's so many different signs and symptoms. There's so many different presentations. Is this a stroke? Is this a TIA? Is this what? Who knows? So you arrive on scene, you look for signs of trauma. Could they have fallen and hit their head? You could have stroke-like symptoms from brain injuries. You could have stroke-like symptoms from seizures. You could have stroke-like symptoms from diabetes, like I mentioned before. Any drugs or alcohol, anything around them, empty bottles of vodka, things like that. There's that deviated gaze I was talking about earlier. She'll look, it's usually more up towards the top of their head kind of look, but it gives you a good idea what it might look like if you see it in the field. This is really common with the hemorrhagic strokes. Their eyes will be open like you see here. They might not be verbal. They might be crying out. They might be saying weird things. I had one lady that had deviated gaze and she was swearing and cussing like a sailor. And she had no idea what she was doing because her brain was damaged by the stroke. Primary assessment really comes down to checking their level of consciousness and their ABCs. People who have strokes, they can lose their ability to swallow, and their mouths can fill up with their own saliva. So you have to make sure they have an intact airway. So if necessary, then you're going to suction them, put them on the affected side, so there's those secretions can drain as this assessment goes along. If they need oxygen, and if their SATs are below 94%, well, this is the time to probably intervene with that. Secondary assessment. So I would do a rapid head-to-toe on these patients with their permission, obviously. And again, most ischemic stroke patients are awake and alert and are they fully aware of what's going on. They're really scared, as you would probably be too if you were having a stroke. They might be able to speak to you. They might not be able to speak to you. Just let them know. You're going to check them out. Just run your hands over their head, their neck, their back. Just make sure they haven't been injured in some way causing this problem today. So after you ruled out trauma, if they are able to follow commands, have them do what's called the Cincinnati pre-hospital stroke scale, and that's that arm drift, facial droop, and slurred speech process. And like this guy right here, he's obviously positive for facial droop. You can see his eye on that left side, the whole side of his face is drooping down on that left side. Get a blood sugar because if they're hyperglycemic or hypoglycemic, then it's probably not an actual stroke. It's probably what we talked about earlier. It's probably a diabetic issue instead, which is easily resolved at the hospital. So here's the Cincinnati stroke scale. Have the person close their eyes, bring their arms up in front of them like you see in the picture here. Their palms go to the sky. As you can see, they're facing upward towards the ceiling. Have them hold their arms up and close their eyes. And the reason why we have them close their eyes is so they can't compensate. And if you see one arm start to fall, it's called pronator drift, then that's a positive finding for weakness on that particular side. And this person would be having a stroke more than likely anyway. Now, when it comes to facial droop, have them smile, and it'll be pretty obvious. And of course, slurred speech. And if you're not absolutely certain what you're hearing is slurred, you could ask a loved one or family member or someone who knows a person well, if there's someone there at scene. You could, I noticed that your wife is slurring their speech. Is this normal or abnormal for her today? And maybe you'll be able to figure it out there. Remember, only one of these has to be positive to be having a stroke, not all three. So sample history. Number one sample history question is time of onset. And you need to nail this down in military time. It's actually county protocol. And county protocol differs a little bit from National Registry protocol, and I'll point those out. So the normal range for National Registry, the window of opportunity, is we'd like to get the patient into the hospital to a stroke center between 3 to 4.5 hours of onset. So if this happens at 12 noon in 12 noon, we'd like to get him into the hospital by 3 in the afternoon. Again, this all comes down to detection. If it happens at noon and it's detected immediately and you get there 10 minutes later and you're at the hospital 10 minutes later, it's not a problem. But a lot of people will not realize they're having a stroke, or their loved ones don't realize it. No one calls 911 for hours and hours, and that's when the window of opportunity gets lost. Record last time the patient was seen normal, or if someone actually witnessed the onset, then the onset of time. Military times, you have to document that. Normally, we would bring a witness with us to the hospital. Because of the COVID stuff, they are going to have us to get the name and the phone number of the person who witnessed the onset or witnessed the last time the patient was normal, and have them stand by their phone because the doctor is going to call them at some point in this process. But we can't bring witnesses to the hospital because of this situation going on now. And what you want to ask, part of your sample history, of course, is their medical history and their medications. And if they're on any blood thinning medications, like Coumadin or Warfarin, or there's a whole bunch of them out there essentially, those make them more prone to having strokes, and also they can limit what the doctors can do for them in the hospital. So ask them if they're on any blood thinning medications. Now, treatment. Airway, suctioning, PRN. Remember, PRN stands for as needed, essentially. Get your oxygen on board. Position the patient. If they're paralyzed or they have secretions, put them on their affected side. So if they're paralyzed on the left side, put them on the gurney on their left side. If they're not completely paralyzed, if they're still able to move their limbs, but they're weak on one side or the other, the county prefers us to put them at 15 degrees head of bed. So HOB means head of bed. You're going to put them on the gurney and you're going to raise the head of the bed about 15 degrees. And the idea behind this is it provides the right amount of blood flow to the brain, not too much, not too little. And that's the ideal. But if they're paralyzed, they cannot move that one side of the body or the other, or like I mentioned before, they can't control their own secretions. You got to put them on their side. That lateral position we talked about way back when. And this is county protocol. So rapid transport to a stroke center, 6 hours to the county of San Diego. So it's twice as much as with National Registry. So you need to know both numbers. You need to know 3 to 4.5 for National Registry, and also 6 hours for the county of San Diego. And on the hospital, reassess, recheck their ABCs, recheck their oxygen saturation, mental status, and don't be surprised that you're going to encounter a patient that they might be a TIA. Their symptoms might improve on the way to the hospital, but they still need to go to a stroke center because of that potential for the big one happening later on. Now, we do get called out for headaches, and my experience has been is the majority of them are migraine headaches that are not controlled. Most people have pretty severe migraines. They take some medications. I think Imitrex is one of the more popular ones there, and I know they're even using a Botox product now for headaches or for migraines as well. But they are time sensitive. You have to take them at the right time usually to make them work. So they might have taken their Imitrex, their headache medication or migraine medication, and they took it at the wrong time, and it did not make them any better, and that's why they usually call us. Now, you call the Starbucks, you got this 42-year-old female with a headache. She was drinking her chai latte, started to feel the pain onset. You do your assessment on her. She's awake and alert. She's got a little bit of slurred speech. She has a little weakness to her left arm. You do a sample history on this. And of course, you're going to ask her when this started and have you fallen at all. You're going to find out her medical history, and she has a medical history of migraines and no other history whatsoever. Her blood sugar is normal, and she's not on any blood thinning medications. So what could you ask her? Well, man, you've had migraines before. I noticed that you have a little slurred speech, and I noticed that your left arm's a little weak. Is that a normal presentation for you? And she says, yes, as a matter of fact, when I get a really bad migraine, I get stroke-like symptoms. Now, I would understand that, and this is not a stroke patient. This is a person having a migraine. But if you have a person with a headache and you can't really explain, or they can't explain why they have slurred speech, or why they have facial droop, or why they have arm drift, then they should go to a stroke center. Now, it might not be a stroke, it might be a migraine, but it's always better to err on the side of the patient's care. And the doctors and nurses would never yell at you or fault you for doing that, because you're erring on the side of the patient. Treatment's going to be exactly the same. If it is just a migraine, I hate to use the word just, I get them myself, but maybe don't make the lights so bright in the back of the ambulance, turn them down a little bit. I've also found ice packs work really well. Have the person hold an ice pack to whatever part of the head works for them. I also have noticed that some people respond positively to oxygen, and I'll ask the patient specifically, have you tried oxygen for your migraines? And some will say yes, and some will say no. No matter what their oxygen saturation is, and it's usually normal, it's 98%, put them on a non-rebreather mask at 15 liters per minute. And what that does is it hypersaturates their tissues, and it causes vasoconstriction. And if it's a migraine, the vasoconstriction will actually reduce the pressure and reduce the pain a little bit. Just a possibility. Ask the patient if that works for them. Some say it does not, some say it does. Take them to, if it's not a stroke, take them to the whatever hospital they normally go to, which is fine. And again, there's different kinds of headaches out there. Vascular headaches, that would be a migraine. Cluster headaches, this is, just areas of the brain that are affected. It can be like they'll feel it on like one side of their head instead of all the way globally over the top of their head. Tension headaches will go down the back of their neck. They'll have that stiff neck going on, and of course they can get headaches from strokes as well as tumors. So again, those are the more serious things. Trigeminal neuralgia, the trigeminal nerve runs on both sides of the temples here, and there's three nerves, trigeminal, there's three nerves, and these three nerves once in a while will kind of bump together and rub together, and that pain and inflammation is excruciating, and it might sound like they're having a really terrible headache, but it's actually these nerves rubbing together. The ones that I see occasionally are the hemisphericals, and these are the people who get the stroke-like symptoms. They have this one side of their brain that's affected by this migraine, and that's why they have these stroke-like symptoms. And it's purely just caused by their migraine. Once the migraine resolves, they go away.